Hello, welcome to chapter 13, micro lecture number 2. And this one we're going to be looking at the nerve plexus and reflexes. This one's a little confusing because it is going to talk about the different types of plexus. So in the different parts of the spinal cord, you're going to have nerves that come out. And those are going to be the basics or the basis of your spinal roots. And most of your muscles, most of your sensory stuff outside of the central nervous system is going to be based on these spinal roots and based on these plexus. So I'm going to go over a couple of them that are going to be very important that people have issues with over time, and I'm going to kind of skip over the other ones. I'll tell you what they are, but those aren't going to be that important. And then finally we're going to finish up with the reflexes. The reflexes are important because this is a good way to test the nervous system without really even doing any scans or any type of difficult types of tests in the hospital. You pretty much hit somebody on the knee and see what happens. You put a little metal rod on the bottom of your foot and you see what happens. So we're going to look at those reflexes, and then we're going to kind of tie them back to your real life experiences and stuff like that. So let's get started. So these are the ones I mentioned before when I talked about nerve plexus. These are going to be coming from the anterior rami branch and that crossing. And this is going to be from one side to another, and then from the one right above it to the one right below it. And it's going to be this, it could be coming from this one, it could be coming from that one. And if you think about it like this, you have single nerves coming out of the brain that form axons. Those axons are then going to be traveling down the spinal cord, and then they're going to be traveling out the spinal cord at different layers of the spinal cord. So all the way from C1, which if you remember back to bones, that's going to be the atlas to the axis to C, all the way down to C7, all the way down from thoracic 1 to 12, and the lumbar is going to be L1 to L5. So you're going to have all these little axons come out, and they're going to come out the front and form a nerve plexus. Because you have them in the neck, it's going to be cervical plexus. Cervical plexus is C1 to C5. And the most important one, we've mentioned it before, this is going to supply the neck, but also the phrenic nerve to the diaphragm. C3, 4, 5 is that spinal root, and those axons that are coming out of cervical nerve 3, 4, and 5, those are going to be supplying the phrenic nerve. Any damage to that part of the neck can damage the diaphragm. Any damage to the main muscle for respiration can damage your ability to breathe. And if you damage that, you're going to be put on a respirator for the rest of your life. So that's why neck injuries are very, very, very important, because they can damage the phrenic nerve that supplies the diaphragm. You have brachioplexus in the shoulder, and that's going to be C5 to T1. It's not in red, so don't memorize it. But one thing I want to point out is, because it's still cervical in the neck, C5 to T1, this is going to supply the upper limb, some of the shoulder, and some of the neck, but also is going to be the basis of the median nerve, which is going to be the nerve that gets pinched within carpal tunnel syndrome, and that flexor reticulum we talked about on the last test. So that kind of brings it all back to the carpal tunnel syndrome. Then we have lumbar plexus in the lower back. Lumbar plexus in the lower back, L1 to L4. So this one's a little interesting because it's lumbar, you think lower back, but this is going to be the abdominal wall, anterior thigh, and genitalia. If you look at the sacral plexus in the pelvis go from L4, L5, S1 to S4, and this is going to be the lower trunk and the lower limb. And you have one important nerve that is coming out of L4 to around S3. And that's going to be the sciatic nerve. And some books might say it starts at the lumbar plexus, but most of them are going to say the sciatic nerve starts at the sacral plexus, because anything going to the lower trunk and the lower limb, that's going to be sacral, and coccygeal is going to be the rest of S4 to S5, all the way to the coccygeals, the coccyx that are the nerves coming out of there. That's going to just be in the back portion. But knowing cervical plexus and lumbar plexus, knowing where they're actually supplying nerves from, that's going to be important. And we'll talk about the sciatic nerve in a little bit. So now we're just going to go over a couple of things, because we talk about this in the brain, we talk about these types of functions. This is kind of where I want to kind of bring all the somatosensory, the somatomotor, and all of that into one kind of cohesive like exam. So the nerve plexes, some of them are going to be somatosensory functions. This is going to be carrying signals from the bones, joints, and muscles in the skin, and proprioception. And this is going to be when the brain receives information about the body. So its position, its movements from nerve endings and muscles, tendons, and joints. Sometimes proprioception can be stretch, sometimes it can be pressure, sometimes it can be overall movement, because if you close your head or close your eyes, you turn your head from side to side, you pretty much know where you are in the room anyway. And that's going to be all this proprioception from muscles, because sometimes those muscles are going to stretch. So these are going to give the brain information on the environment. So is it hot? Is it cold? Is there too much pressure on a joint? Is there something, some stress on bones? This is all going to be sent back to the brain. And then it's going to be motor. This is going to be to move the muscles, to contract them, to get them out of those situations. So if your joints are kind of strained, your muscles are going to relieve that stress. And one kind of way to think about it is somatosensory goes into the brain, motor is going to go out of the brain to the muscles. So one's going to be afferent, going to the brain, and then the other one's going to exit the brain and be efferent. But we're going to cover those words and terms when we talk about the brain itself. Another thing you might have heard of is chickenpox. So this is a common disease in early childhood caused by Varicella zoster virus. Very itchy rash that clears up without many complications. Sometimes it moves into the mouth, sometimes it goes into other areas, and it can get very uncomfortable. But most of the times you get chickenpox, you're good to go. The problem with chickenpox is it remains for life in the posterior root ganglia, or the dorsal root ganglia, as some books would call it. That's going to be this little bundle of cells in the back. And what happens is every time they try to leave the posterior root ganglia, they keep getting destroyed by the immune system. But when you get older, shingles, herpes zosters, this is a localized disease caused by the virus traveling down the sensory nerves by fast axonal transport when the immune system is compromised. So when you get older, after the age of 50, what happens is your immune system isn't as efficient as it used to be, and then it will leave a painful trail of discoloration and fluid-filled vesicles along the path of a nerve. So you see these like little red stripes going down your arms, going down your chest, going down your waist, and they're going to be on usually one side of the body, not both, because the immune system is going to be able to check one. It's very, very painful and itchy, because you think about it, if you have this going through your nerves, there's no way your body can actually fight it off. So it's very, very painful. You have to take a lot of drugs. People do get over it, but it is very painful, and it's very, very, very kind of uncomfortable. And there is evidence that chickenpox vaccinations reduce the risk of shingles later in life, because if you can stop chickenpox from getting into the dorsal root ganglia, you can stop them from forming shingles later on. This is just a look of the cervical plexus, and you can see C1, 2, 3, 4, 5. One interesting thing about this, and we didn't really talk about this in any of the other slides, but if you see here, this is going to be the atlas vertebrae. The first cervical nerve, or nerve root, comes out above it. So C1's up here, C2's just below it. So even though you only have 7 cervical vertebrae, you're going to have 8 cervical spinal roots. And if you look here, the phrenic nerve has part of C5, part of C4, and then part of C3. And there is some variation between people because this is based off of these axons coming out and then forming the root of the phrenic nerve. Some people might have more of C4 or C5, some might have more of C3, C4, and then just a little bit of C5, but most people are going to have axons coming from those 3 spinal roots to make up the phrenic nerve. The brachial plexus is right here, and here you can see C5, 6, 7, and 8. I mentioned why there's 8 cervical roots instead of and only 7 cervical vertebrae, because number 1 comes out on top. Here you can see the median nerve. Median nerves coming from part of 5 and 6, part of 7, and then part of 8 and T1, and all of that's going into the median nerve. The axillary, the radial nerve, the ulnar nerve, these are all going to go down in the hand region. And if you look at it, this is your brachial plexus in a cadaver. And when I took this in gross anatomy, the only thing I kind of looked at when I saw this was, wow, if you get stabbed in the shoulder, there's a good chance you're going to lose the ability to hold on to something. So you see all those Die Hard movies or Terminator movies where they get shot or whatever in the shoulder and they're still holding on to the gun. Well, there's a good chance that if you hit one of these nerves and these nerve roots, they're not holding on to anything because they're going to lose the sensation of those muscles in their hands. This is the lumbar plexus. The lumbar plexus is going to start at L1 all the way to L5. I know it said L4 in the other slide. That's the sciatic nerve right there coming down. But if you kind of look at this, the sciatic nerve is actually going to be in the sacral plexus. And you can see 4, 5, S1, S2, S3, all of that's going to be the root for the sciatic nerve. And you see how thick the sciatic nerve is, coming all the way down, having 1, 2, 3, 4, 5 different spinal roots that make up the sciatic nerve. And like I said, it's the largest, thickest. You can see it right there. It's very, very, very big. And it is the reason why most people are going to have lower back injury. So let's look at these individual nerve injuries right now. So the radial nerve. Radial nerve is going to pass through the axilla or armpit. Crutch paralysis. So if you have a crutch, you have it, you're gonna have your wrist feel very, very, very weak, and this is going to be caused by the crutches pushing into your armpit and stopping the radial nerve from sending the signal down to the wrist. The other one, sciatic, you've heard about it, sciatica. You've definitely probably heard of that from older people or just people, your friends and family. If you're an athlete, you hit you carry something wrong, you walk wrong, you get hit wrong, this is what's going to happen. This is that sharp pain that travels through the gluteal region along the posterior side of the thigh, leg to ankle. In 90% of these cases are from herniated intervertebral discs or osteoporosis of the lower spine. But you still have 10, maybe 15% in some cases that's just caused by their gait, caused by the way they walk, caused by the way they hold things, stuff like that. And this is just going to be impinging in that lower back region. That's going to pinch on any of those spinal roots that make up the sciatic nerve. That's going to pinch on that, and that's going to cause this really, really, really intense pain. And because this is such a large nerve, most of the injury in the lower back is going to be caused by sciatica. And now, none of this is in red, so good for you. These are just dermatomes. So if you're ever wonder why a doctor will touch different parts of the body, different parts of the skin are going to relate to spinal roots. So if you have muscle damage or inability to move a muscle, a doctor can touch these dermatomes on the body and they can read back to, is it going to be a muscle at the periphery, at the muscle itself, or is it going back to the spinal root? So dermatomes are a very important way to kind of make sure you can see if you have nerve damage in the spinal cord or in the peripheral nervous system. So now let's look at reflexes. So what's a reflex? And how does a reflex differ from other motor actions? What are the general components of a typical reflex arc? We're going to look at a couple different ones. And then we're going to explain how basic types of somatic reflexes function. But first, let's look at the definition. Reflexes, quick, involuntary, stereotyped reactions of glands, muscles, or to stimulations. So it's an automatic response. to sensory input that occur without our intent or even our awareness. Touching a hot stove, you don't need to think about it, you just pull your hand away. Stepping on something sharp, your leg gets pulled back. All of these things are stereotyped in a way to try to make sure that our body is safe, we don't burn our skin, we don't step on something sharp, and so on and so forth. So now let's look at the major properties of a reflex. They require stimulation. So they're not spontaneous action, but something needs to have a sensory input first, and then they can react to it. They're very quick. They involve few, if any, interneurons. So it means it goes up one neuron, out another neuron, it goes into the spinal cord and back out. Not many interneurons at all, because interneurons are going to take acetylcholine, epinephrine, dopamine, other types of neurotransmitters to be released, and then they have to then act upon the synaptic cleft and the receptors. This one's just one to another, and so they're very, very, very quick. You have no control over them. So you don't even know they're happening in most cases, and they're automatic. And they're stereotyped. And this means they essentially occur the same way every time. Which means if you step on something sharp, your foot goes up. You touch a hot stove, your hand's going to be pulled away. That's what stereotype means in this case. Now, they include glandular secretions and contraction of all three muscle types, so smooth, cardiac, and skeletal. Some are going to be learned responses, conditioned reflexes, so some of these can be learned over time. And we're dealing with unlearned skeletal muscle reflexes mediated by the brainstem and spinal cord. So even though sometimes you can have a learned response from a food type that you don't like, where you just your stomach gets, maybe the glands in your stomach start secreting stomach acid, makes your stomach feel uncomfortable, and you don't want to eat that food. That's not the ones we're going to be looking at for the rest of this micro lecture. Then we're going to look at somatic. And since they're involved in the somatic nervous system, that's why they're going to be called somatic. And we'll review somatic reflexes and the somatic nervous system later on in this semester. So the pathways. You have receptors for somatic in the skin, muscles, or tendons. Afferent. Afferent's always going to carry it into the spinal cord or all the way up to the brainstem. Then it's going to be that interneuron, the integrating center. This is going to be where synaptic contact between the neurons and the gray matter in the spinal cord or brainstem. This determines whether the efferent neurons issue signals to the muscle. So that little integrating center just determines, does it send it up to the brain, or does it send it to the efferent that's going to carry out the motor impulse to the skeletal muscles. Then the effectors. This is the somatic effectors that carry out the response. So none of this is in red, but it is important to know that something needs to be felt, then it needs to be brought in, then it needs to be looked at, then it needs to go back out, and then there needs to be something that it signals to cause an effect. And this brings us to the muscle spindle. This is the stretch receptors embedded in the skeletal muscles. This is a way for our body to feel what's happening within a muscle cell. And this is proprioceptors, specialized sense organs to monitor position and movement of body parts. So coordination, if you're moving it too much, these are all going to be parts of this type of muscle spindle. And the reason why I'm introducing this term is because the next reflex is based off of this type of receptor. And they're going to inform the brain of muscle length and body movement, and enables the brain to send motor commands back to the muscles to control coordinated movement, correct reflexes, and muscle tone and posture. This brings us to the stretch reflex. So the myotatic, or the stretch reflex, is when a muscle is stretched. It tries to fight back and contract. So somebody pulls your arm, it's stretching the muscle, you're going to want to pull it back. And this maintaining increased tonus and making it stiffer than an unstretched muscle. This helps maintain equilibrium and posture. So all of you have done this at one time in your life. You're falling asleep in class. You're reading a book. When your head starts to tip forward as you fall asleep, the muscle starts to feel that it's stretching even though it's not supposed to. This is going to contract the muscles and it's going to have your head jerk back up. So every time you're doing this in class, hopefully it's not every time or a lot, but every time your head jerks forward when you fall asleep by listening to something, this is an example of the stretch or myotatic reflex. You also have ones in the tendon where they stretch, and then so when the contraction of a muscle, when the tendon is tapped, this is going to be your little knee-jerk reaction in the hospital. And what I want to kind of just show you with this is just what's going on with this. It's not in red, but tap this, and then it sends a signal up. Tap on the patellar tendon, the nerve endings. It's going to stretch signal is going to be sent to the spinal cord up here, and then it's going to send it back up, and it's just going to cause your leg to jerk forward. Another one that you probably all have been aware of, step on something sharp. Step on something sharp. The receptor in the foot is going to be okay, that's something sharp. It's going to send the signal back up into the spinal cord, and then it's going to send it back out. One interesting thing about this, it's going to raise the leg up, but it's also sending things to the other side, making sure the other leg is going to have the tone so you don't fall over. So it's very interesting to know there are multiple things going on when you step on something sharp, because yes, you want to get your leg away from that stimulus as soon as possible, but you also don't want to fall over. So you're also going to have that contralateral motor neurons to be causing the stability so you don't fall down. And that's all that's kind of talking about on those last two slides. And the muscle tendon reflex, this is just showing you that there's neurons and there's nervous tissue on the tendons, just to kind of be able to show you that when the tendons stretch, there is going to be receptors there to make sure that it knows when they actually do stretch. And then finally, spinal cord trauma. This happens a lot in the United States and all over the world. 10 to 12,000 people a year are paralyzed and have some sort of spinal cord trauma, usually by vertebral fractures. Vertebrals break into two different parts, and then they damage the spinal cord below it. Highest risk group is males, 16 to 30. That's mostly because they have high-risk behavior and stuff like that, like automobiles and motorcycle accidents. And then just to finish off this chapter with spinal cord trauma, you can have a complete cut. So that's a complete cut of the spinal cord. This is the immediate loss of motor control below the level of the injury. Above C4 causes threat of respiratory failure because of the phrenic nerve. You can have spinal shock, paralysis, and paralysis is just going to be paraplegia is going to be lower limbs. So it's just para 2. Quad is going to be 4. So all the upper limbs and the lower limbs. Hemi, mostly stroke victims and stuff, this is when they're paralyzed on one side of the body. And then paresis is partial paralysis or weakness of the limbs. And this can be in diabetes and other things like that, where blood flow can damage the nerves, and then this can just be weakness of the limbs. Muscular dystrophy, it starts like this too, but that kind of gives us an idea of what's happening in the spinal cord.